Our next speaker is Christine Kempton, who will be talking to us about management of bleeding patients in a new era of new anticoagulants.
Okay, well, thank you for the invitation. I'm excited today to be here to talk about management of bleeding in the era of direct thrombin and factor Xa inhibitors. These are new medications that we're all becoming more familiar with. So as an outline, I'll kind of give some background, as we may have some varying familiarity with the new direct oral anticoagulants. You may have heard them referred to as novel oral anticoagulants, new oral anticoagulants, target-specific oral anticoagulants. There's a move to try to have more consistency with the terms, and I'm trying to use the one as direct oral anticoagulants, which some of the societies are trying to use more consistently. We'll talk about the safety, some of the laboratory aspects of how the medications may affect laboratory assays and how you can measure levels. Specifically, then, management of bleeding when a patient does come into you on these medications and they're actively bleeding. And then when you need to actually induce something that's going to be causing bleeding, you're going to be inducing trauma through surgery, how are you going to manage it and potentially reduce and stay out of having a major bleeding problem? So my talk wouldn't be complete without a nice coagulation cascade that may make everybody a little scared. The warfarin, which we're familiar with, we know that's a vitamin K antagonist, so that's going to be affecting 2, 7, 9, and 10. Heparins are acting through antithrombin, are going to be affecting factor 11, factor 9, factor 10, and factor 2. The low molecular weight heparins, like enoxaparin that you're familiar with, predominantly affect factor 10, but have some effect on factor 2. So with that, some of the newer medications that have been produced are directing factor 10, which is here right in the center of the common pathway. The ones that were first on the market was rivaroxaban, and I'm going to refer to them by their generic names, but the trade name is Xarelto. The next on the market has been apixaban or Eliquis. Just approved is edoxaban, and then coming down the pipe is betrixaban. So I'm going to pretty much focus mostly on rivaroxaban and apixaban, though a lot of the principles are going to be similar for edoxaban and betrixaban. Over here, targeting thrombin, the oral agent that's available is Dabigatran. There are some IV medications that are available would be argatroban, Hirudin, and bivalirudin. So to understand a little bit about the action and why they're different than some of the parenteral anticoagulants, the rivaroxaban, apixaban, and the other direct oral Xa inhibitors bind Xa itself. They don't need any other adjunct such as antithrombin, as unfractionated low molecular weight heparin and fondaparinux do. So they're directly inhibiting factor 10. This allows it to inhibit the thrombin that is circulating, or the Xa that is circulating, and clot-bound Xa, having a theoretical advantage, though not one that's necessarily borne out as superior efficacy in clinical trials. Dabigatran inhibits the active site of thrombin, also does that, again, directly. It doesn't need any antithrombin to do so, as the unfractionated heparin does. And because of that, again, is able to bind both soluble and thrombin-bound, or fibrin-bound thrombin. So for a comparison of kind of what are some of the differences between these medications, Dabigatran, being our only direct thrombin inhibitor here, is actually a prodrug that is converted to the active drug. They have similar elimination half-lives, though interestingly, apixaban is the only one that's, actually, Dabigatran and apixaban are both twice-a-day medications, where rivaroxaban and doxapan are once a day. The renal clearance is definitely different and may make some differences in how you're approaching bleeding or what choices patients may be on. And then the effect of the CYP inhibitors is different between Dabigatran and the other medications, and they're all affected by P-glycoprotein substrates. So when we're approaching, or when we see somebody with bleeding, it's always easy to say, oh, that medication, and particularly the new oral anticoagulants, I think, as you see a patient with bleeding on it, kind of say, it's that medication, and that's bad. And you may have all seen, or maybe you're not watching TV, but you'll see the lawyers kind of wanting to get calls on the patients that have had problems with the Dabigatran and those sorts of things. So I think it's easy to kind of, jump on that these are bad medications and we need warfarin, and it has a more, we're more comfortable with it. But the clinical data suggests that there's overall a lower bleeding rate with the direct oral anticoagulants than the vitamin Ks. And these are a series of data from a meta-analysis from the large trials that were done in patients with AFib and venous thromboembolism. And you'll see here that the overall estimate is in favor of the direct oral anticoagulants with a lower bleeding rate. This is particularly with intracranial hemorrhage, which is kind of the worst of the worst with respect to anticoagulant bleeding, that it favors the direct oral anticoagulants having a lower rate of intracranial hemorrhage. And I'll say this now and I'll say it again because I think it's an important point. The best method to manage intracranial hemorrhage is just not to have one. So from this perspective, it favors the direct oral anticoagulants. Despite all that we do to manage an intracranial hemorrhage, even with, with appropriate reversal with the warfarin, we're not very good at it. So it's just best to not have it in the first place. GI bleeding is the one area where it's more equivocal, and actually there's some of the direct oral anticoagulants may have a slightly higher rate of gastrointestinal bleeding. So a patient that is at high risk for gastrointestinal bleeding, maybe with a past history of it, may not be as good a candidate. Again, overall, the point estimate is is neutral, but there's some of the clinical trials did show an increased incidence of gastrointestinal bleeding. Risk factors for bleeding, same as that with warfarin or any other anticoagulant. In patients with AFib, a higher CHADS-2 score, concomitant use of antiplatelet agents, advanced age, organ dysfunction such as renal insufficiency, liver disease, prior major bleeding, or uncontrolled hypertension. Those are the patients that are going to have the highest risk of bleeding. And that's going to be whether it's a direct oral anticoagulant or warfarin. Those are the problem patients. So you're getting a patient, say they're having some sort of bleeding symptoms, and you kind of want to know how much drug level do we have around. That is a little bit tricky. So with our general anticoagulant tests, the one that we commonly use, maybe the APTT, the PT, eccrine clotting time, thrombin time, those are some of the typical assays that we may be performing on patients who are having bleeding, and we want to understand what's going on. So they're going to affect these tests differently. Dabigatran is going to prolong the APTT significantly and substantially more than the PT. And this is going to vary depending on the reagent. So one lab may have an APTT affected a whole lot more than another lab. The thrombin time and eccrine clotting time are both very sensitive. So pretty much any circulating dabigatran is going to lead to a prolonged thrombin time. So this is in the setting, say if you want to know, does a patient have any circulating dabigatran around? Can they go to surgery if they need to? A thrombin time is going to be prolonged. So a normal thrombin time is a good evidence that you don't have any dabigatran. But a prolonged thrombin time doesn't mean you have a significant amount of dabigatran circulating because it's very sensitive. Drug levels can be measured, and it's a similar assay using a dilute thrombin time that has specific standards that are using drug standards. The problem is none of these are FDA approved. There's a lot of variability from one assay to another. Additionally, outside of just knowing you have drug on board, there's not really good clinical correlation to what does it mean. Is this patient at risk for having a thrombotic event, or is this patient at risk for having bleeding? At what level could we safely go to surgery? But all the studies in atrial fibrillation and venous thromboembolism were designed to be easy for the patient. Patients hate going in and having monitoring. So they were designed not to have monitoring and not to have drug levels. And the big studies, they're kind of going back and evaluating what were the drug levels in the patients that had thrombotic events or had bleeding. But that data isn't quite yet available, and even so, it's a little bit difficult to interpret. Since dabigatran has been around for the longest, there is one manuscript available on dabigatran in this. From this data, they then modeled for a patient, and this is a 72-year-old with atrial fibrillation, and they modeled with knowing the drug levels up here, and then the likelihood of an ischemic event, the likelihood of a bleeding event. And you can note on this, one, that the drug levels were hugely divergent. So, and that was noted in the clinical trials, was that lots of people who didn't have thrombotic events or didn't have bleeding events had really varied drug levels. So that makes it really difficult to know, at least from a kind of safety and efficacy standpoint, what should a range be. You can see, though, and then that there's a lot of overlap as well between the bleeding events. This is probably your therapeutic range. Too low, you're going to get thromboses, and too high, you're going to get bleeding. But exactly where and how to interpret and what's the right level is still a challenge, and that will be evolving, I think, over time. For the direct 10A inhibitors, the PT is going to be more affected than the APTT. And apixaban has absolutely no effect on the APTT, whereas rivaroxaban with the PT will prolong it greater than apixaban. However, a normal PT does not exclude significant drug concentrations of either of the oral 10A inhibitors. So in contrast to Dabigatran, where a thrombin time is kind of super sensitive and you'll kind of know anything is circulating, with the 10A inhibitors, the problem with them is that you really don't pick up much of the drug levels at all. So you could have significant circulating levels and have normal coagulation parameters. Again, there are drug level assays that are available in kits that can be done. We do them at Emory. And it's basically a modified chromogenic anti-10A assay, very similar to a low molecular weight heparin level, but using specific calibrators for the apixaban and the rivaroxaban. So what to do when a patient now comes, they're now in the emergency room and they're having bleeding. And so first of all, easy, just don't give them any more anticoagulation. We got all that one down. If they've taken their dose within 2 hours, you can use charcoal, kind of non-specifically binding the medication. Most of the time, the other patients will have taken it in the morning, or it's going to have been longer than 2 hours from their last administration. So then this is where you kind of need to know the half-life and how long is this drug going to be circulating. And this is where one of the benefits is that the half-lives are not particularly long. So in a lot of patients, the drug is going to be eliminated in a normal time frame, and supportive care is going to be adequate. The direct thrombin inhibitor, so Dabigatran, is affected by renal clearance. So in patients with reduced renal clearance, you're going to have a much longer half-life, and it's going to vary. And you can see up here that in those with a creatinine clearance less than 30, the half-life is now over 48 hours. So you're going to have a long time with drug circulating. So while you're waiting for that medication to clear, you want to do the usual general measures, local hemostatic measures, transfusion therapy as needed for anemia or thrombocytopenia, tranexamic acid, and antifibrinolytic can be used as well as an adjunct. With Dabigatran, you can increase the clearance. It is not significantly protein bound, so you can remove a good proportion of it using dialysis. That isn't the case with rivaroxaban or apixaban. It's too much protein bound in those instances. So with dialysis, you can remove about 60% of the Dabigatran. However, you may see somewhat of a rebound after the end of dialysis. So after you've done those things, you're not giving any more anticoagulation, you've done charcoal if you could. In patients with with really reduced kidney function, you've considered dialysis. You don't need to do dialysis in patients with a normal renal function. It's not going to be as useful even with the Dabigatran. And they're still at risk for morbidity related to their bleeding. It's still pretty significant bleeding. Then you can look at agents to promote hemostasis. Those would be your prothrombin complex concentrates, or activated PCCs, or recombinant 7A, Novo-7. So the 4-factor PCC, Kcentra, was approved, I think, within the last year, and that contains factor 2, 7, 9, and 10 in an unactivated form. Bebulin is another PCC that may be available, and that does not contain factor 7, so it's just 2, 9, and 10. An activated prothrombin complex concentrate goes by the name of FIVA, and it contains also 2, 7, 9, and 10, and activated factor 7. It may have very small amounts of other of the activated factors. And then Novo-7, which is recombinant factor 7A. They've all been shown in animal models to improve coagulation laboratory tests. How effective they are at improving bleeding and hemostasis in patients is all pretty much anecdotal and based on case reports at this point. Dabigatran, again, it's been out the longest, so there's information that's available out there on it. There's variable success with recombinant 7A and PCCs, but the case reports are reporting more successful management with APCCs. 5 reported cases, the doses ranged from 25 to 100 units per kilo. These were, 1 dose was received for the management of hemopericardium, intracranial hemorrhage, and GI bleeding. So as a kind of a general approach, this is, again, very much kind of expert opinion, given the absence of data on this. But for the first line for Dabigatran would be 50 units per kilo. This is the APCC. For the factor Xa inhibitors, for rivaroxaban, apixaban, edoxaban, and eventually betrixaban, Kcentra, also 50 units per kilo, both given once. If those are ineffective, then move to recombinant 7A, a dose of 90 micrograms per kilogram, and would reserve these agents for significant bleeding. In those with mild or moderate bleeding, waiting with supportive care is going to be enough. Again, the point with intracranial hemorrhage, the mortality associated with warfarin-associated intracranial hemorrhage is about 30 to 40%. This is even with vitamin K and good reversal with a 4-factor PCC. So standard of care, best management, mortality is still 30 to 40%. And Dabigatran and warfarin-associated mortality is the same. So again, these medications have the potential to reduce that. Some patients are going to come in with these complications. That doesn't mean that these medications are the bad actors in that instance. Clearly, some patients may not be managed with it, and they may not be the best candidate for it, but in a good candidate and an appropriate candidate, it's not the medication necessarily. So with perioperative management, there's specific guidelines in terms of the timing that you need to be holding the medication prior to going to surgery, longer for those with renal dysfunction in Dabigatran. With neuroaxial anesthesia, probably want to hold a little bit longer, 5 half-lives for the medications, longer with renal insufficiency in those with Dabigatran, and you want to restart it 24 to 48 hours after removal. Postoperatively, you're going to restart your direct oral anticoagulants once full anticoagulation is allowed, which will likely be 48 to 72 hours after major surgery. In patients, particularly those with history of venous thromboembolism that are high risk for recurrence, surgery is a risk factor for developing a VTE, so they're going to need prophylactic therapy, even if you're not ready to restart their full dose anticoagulation. So in conclusion, direct oral anticoagulants are safer than warfarin. The lack of monitoring or reversal doesn't lead to worse outcomes. Bleeding management is predominantly supportive, and PCCs or APCC can be used in the setting of limb or life-threatening bleeding, though clinical data is absent. Thank you.